Okay, so my name is Johannes, and together with Evan and Brad, we're going to take the opportunities to talk about traumatic injuries and immediate treatments for the next roughly hour or so. And very excited to have such an international audience, lots of little differences of how things are done across the world. But I think some very sort of key principles should be similar and applicable to wherever it is that you're working. And just to set the premises for this talk a little bit, there's a whole bunch of traumatic injuries. There's lots of different things that go wrong. As you know, trauma doesn't respect anatomical boundaries. It doesn't respect rules or textbooks. It's a very variable thing to happen. So at the same time, there's also a lot of things in terms of medicine that we can do for traumatic injuries. And just to focus this talk down a bit, what I want to talk about today is traumatic injuries that are going to cause some real harm to patients, so life-threatening injuries. But not only that, they have to be injuries that are actually amenable to something we can do at scene during extrication, where we have actions that first responders can undertake to prevent loss of life and improve function down the line. And to do that, we're going to break it down into 3 parts. Evan is going to start with a structured approach to initial assessment and treatment. So actually start way before the patient gets injured in terms of your mental preparation, your team preparation. How do you assess the traumatically injured patient? And we're borrowing a structure from the military, which really hones on that concept of, focus on the life-threatening injuries, do what you can under limited resource environment, and then move on. Then I'm going to talk about 3 high-yield injuries and treatment considerations, again, focusing on life-threatening early interventions. And Brad is going to finish up with a few challenging cases. So with that, I'm going to hand over to Evan, who I think had some connection difficulties, but hopefully that has improved.
Hi, folks. I think that's working here. I think we got that under control. So welcome. Thank you, everyone, for coming. We understand it's sort of all times of the day and night, so we definitely appreciate you all being here. And again, we realize and recognize that there's sort of all levels of providers and clinicians here, so hopefully there's something to take away for everyone. So my name is Evan Hanna. I'm a critical care paramedic and educator with Orange, and my background is a tactical paramedic, so I like trauma. So we're going to start off with a structured approach to just the initial assessment and treatment of trauma, as Johannes mentioned there. So this is just a basic structured approach, really focused on the first few minutes and what's going to kill your patient in these first few minutes during extrication and immediately afterwards. It's really less important which structure you use. There's the ABCDE model, there's the March model, which we're going to take a look at. It's more important to consistently use something that you can fall back on, just to make sure we're covering everything and not missing anything here. So as I said, we're going to have a look at the March approach to initial assessment and treatment. So this is just a structured approach to identify some major causes of preventable death, specifically, as Johannes mentioned, in battlefield trauma. So these were derived from some really interesting combat casualty analyses of potentially survivable injuries. First done back in Vietnam, and the most recent one is Death on the Battlefield by Eastridge et al. It's a really interesting read if you want to have a look at that. And while these are really specific to battlefield trauma with a much higher incidence of sort of penetrating and blast injuries than we're likely to see in our MVC patients, the principles are still very useful for the assessment and treatment of all patients. So March stands for massive hemorrhage, airway, respirations, circulation, and hypothermia. And we'll add a little something to the end there once we get there, but we'll go through these one by one and just have a quick run over them. So massive hemorrhage, 91% of these potentially survivable patients back in Vietnam died from hemorrhage. And also, if we look at civilian preventable death and trauma, the majority of that is also due to hemorrhage. So your big ticket items, low hanging fruit here is use tourniquets early on any extremity hemorrhage that's really thought to be life-threatening. Now, thought to be life-threatening is your catastrophic, holy cow, oh my God, it's bleeding a lot. So if you can get a tourniquet on it, that is the most effective, most efficient way that we can stop that bleeding as fast as possible. And this is really where seconds and minutes count. For any compressible hemorrhage that's not amenable to tourniquet placement, so any of your sort of junctional, up in your armpits, or anything on your torso, anything you can't get a tourniquet on, just use direct pressure with a pressure dressing. Ideally hemostatic if you had it, but any pressure dressing will do. And ensure that you just keep pressure on that for as consistently as you can to allow that clot to form. And at this point, we'll assess for altered mental status. So are they able to speak to you? Are they able to tell you their name? And that's obviously like a key sign of shock. But this is really those, if we don't do something in the next few seconds, we're going to have a problem here. Another way of remembering this, if you like your acronyms or these sort of tools, is the 4 Ds of massive hemorrhage. So that's detect, find the source of bleeding, direct pressure, get some pressure on there, like we said, hold it until the clot forms. Devices, whether that's tourniquets, hemostatic dressings, or your more commercial trauma bandages, and then don't dilute. So we always want to avoid excess crystalloid administration unless absolutely necessary. So next is Airway. So our A stands for Airway. Now this comprised, again, these are battlefield stats, but about 8% of preventable combat deaths in the 10 years during the Iraq and Afghanistan wars. So for assessment, we're going to look for signs of obstruction, whether that's just obvious blood in the airway, obvious trauma to the airway, whether that's an expanding hematoma. We're going to listen as much as we can. I know these are noisy environments, but listen as much as we can for normal ventilation. And honestly, the easiest way is to just get your hands on the chest and feel for chest rise and fall. It's the easiest way to really know if their airway is compromised, if they're getting air into their lungs and out of their lungs. Just keep it very simple. Some of these airway problems are going to include maxillofacial trauma, so trauma to the face, the jaw, laryngotracheal trauma a bit lower down, decreased GCS, so unable to protect their airway, as well as neck trauma that might cause an expanding hematoma that could put pressure on the trachea. Some basic maneuvers are effective in the majority of these cases. So your very simple jaw thrust, again, in terms of our C-spine considerations, we can always do that modified jaw thrust. Someone sitting up in a car seat, you can go put your thumbs right up on their sort of cheekbones, do a nice jaw thrust, and honestly, that alone is going to help in the majority of your airway issues. Nasopharyngeal airways are great, very simple to use. Suctioning, if you have it available, and BVM ventilation is always great. But as you can see in the picture there, this is a nice, well-lit patient supine position to be ventilating someone in. And I'm sure many of you are very, very experienced. You could see how difficult this would be to do in a vehicle. So just really emphasizing that if we do have any of those major issues, whether that's massive hemorrhage, airway, or respiratory, then we need to get that patient out as soon as possible. And we'll want to monitor the airway closely, as airway size can obviously change over time. So respiration, again, going back to the battlefield stuff here, we have to adapt this slightly. March really focuses on identification treatment of penetrating chest trauma and prioritizes these vented chest seals, decompression of tension pneumothorax. We're not quite as likely to see that in these blunt trauma patients. I don't want to rule anything out. We've all seen some interesting things, but we're far more likely to experience blunt trauma like seatbelt injuries, steering wheel injuries, especially in patients who are not restrained. And the types of injuries we might see here are rib fractures, flail segments, so a section of ribs that are broken in more than one place, creating that big segment that can kind of move in and out freely and really impairs respiration. Obviously, we can see pneumothorax, and then cardiac and pulmonary contusions, which are much more underlying. In terms of treatment for respiration, we're going to want to assess for absent breath sounds if possible, really just looking for unequal chest rise and fall and increasing respiratory distress in the presence of chest trauma. So if you are trained and authorized, if we identify these tension pneumothoraces, then this is the point where in our assessment and treatment that a needle or finger thoracostomy would be indicated. And we can always use SpO2 plus or minus end-tidal CO2 if it's available to you to monitor this in some of your longer extrications where you might be monitoring these patients for quite a while. And we can use some supplemental O2, just targeting an SpO2 of greater than 90% is fine. If you do happen to have some sort of penetrating chest injury, then again, obviously we want to emphasize putting a vented chest seal or just making a 3-sided occlusive dressing. And really that's any injury from neck to umbilicus, just to be safe and cover anything that could have penetrated the thorax and the lungs. Remember, more likely than penetrating injury here that's open is an impaled object. So remember, if there's any impaled objects, we want to leave them in place as they're likely tamponading any bleeding inside. And we want to stabilize, cut these as necessary, and extricate. All right, circulation. So there's sort of, we're covering circulation twice here. So massive hemorrhage right off the start. You're, oh my God, bleeding, and deal with right away. And then we circle back to this after airway and respiration. So what's the skin condition? Are they pale, cold, clammy? Is there signs of shock? A great time to assess a radial pulse, and a really quick way of assessing perfusion is just to do a cap refill test. So chest and forehead is very useful for a sort of central cap refill, and you can check the nail beds as well. Less than 2 seconds is generally good. 4 to 5 seconds or more is generally pretty bad. But remember that this is temperature sensitive as well, so you'll have to take that into consideration. This is the point in circulation where we'll also talk about pelvic binders. So these should be applied for any suspected pelvic fracture. So indications for this are going to be any pelvic pain or instability, any high-risk mechanism, or in any patient where you have shock without an obvious cause. It's very reasonable to put on a pelvic binder. And the goal with that being to sort of, if we did have an open book pelvic fracture, which you can see an image of to the right there, that we sort of close that potential space and sort of try to tamponade any bleeding that might be occurring there. This is a great time to reassess any tourniquets that you might have placed. If one is ineffective, we can tighten it, or we can put a second one above the first tourniquet. And hopefully control that hemorrhage. And this is the point in time as well that if you're trained and authorized, we'd be looking for IV and IO access. Again, emphasizing really minimizing crystalloid administration. If you are with a service that has blood on board, then that's fantastic. But really emphasizing hypotensive resuscitation. We want to really keep that map enough that we're perfusing and the blood pressure enough where we're perfusing the brain and our vital organs, but we don't want to, blow these clots off that have been so preciously formed there and are keeping us from bleeding. And obviously in the traumatic brain injury patient, we'll use slightly higher targets for that. Hypothermia is sort of the last part of March here, and is, despite being last, very important. So it's a critical part of the trauma triad of death. So that being comprised of hypothermia, acidosis, and coagulopathy, and more recently, sort of hypocalcemia, if you want a diamond of trauma triad. Hypothermia results in significantly increased mortality in trauma patients, and this is mostly due to impaired coagulopathy, but they sort of all beget each other. So we actually contribute to this in several ways. We expose patients to identify injuries. There's the old adage of strip and flip. We administer cold IV fluids to them, and they have prolonged exposure to the elements during extrication, right? So if you're in a car with a smashed windshield and it's minus 20 outside, and you take an hour to extricate, well, they're going to be pretty cold, and that's going to contribute significantly to their mortality. So what can we do? It's essential to minimize heat loss here during all stages of patient care and extrication. So immediately after we expose the patient to identify and treat their injuries, we want to recover that patient. So we should be aggressively recovering the patient as soon as possible with blankets to protect them from the elements. We should be removing wet clothing, obviously as much as you can with a trapped patient, but you might have limited access. And we want to try to place insulating material between the patient and any cold surface. That includes the ground, that includes fracture boards or spinal boards if you're using them to remove the patient from a vehicle, and active warming as whenever necessary and available. And again, if you're giving IV fluids, if you can warm them, that's fantastic. The last part we'll talk about here is fractures. So March, designed for battlefield trauma, is the sort of quick and dirty, what's going to kill you in the next 5 to 10 minutes. But obviously in blunt trauma, we're going to see a lot of fractures. So it's not explicitly addressed, but very common, is going to result in significant pain, especially during extrication. and should be identified and supported in place with movement minimized whenever possible. So if there's no life threats to this patient imminently and they have significant sort of orthopedic injuries or fractures, then I think it's a time where we can slow down, work together with our advanced providers if they're available, or if you are one yourself, to provide analgesia prior to extrication if that's possible and when the delay is appropriate. Okay. That being said, I will hand that over to Johannes. Thank you.
Excellent. Thank you, Evan. That was great. So just to, I guess, quickly recap that, everything in pre-hospital care, whether that's during the initial assessment, extrication, or following the next further more detailed assessment following extrication, everything we do in trauma is a trade-off against time. And therefore having this structure and having a focus on what's actually going to make a difference for the patient, limiting ourselves to what's going to make a difference is a real key aspect of that. And having a structured approach, like Evan said, whether that's March or whether you prefer your ABCDE, having a structured approach is really vital to be successful in that. So I guess just a quick introduction on me. My name is Johannes. I'm an emerge physician working here in Toronto at St. Michael's Hospital, which is one of the 2 regional trauma centers covering both the city of Toronto as well as quite a large surrounding area with many rural, high-speed roads, plenty of head-on collisions and trauma. Before here, I worked in the UK in Bristol, where I did my training. I worked with the Great Western Air Ambulance there, plenty of scene response to trauma, and then did a 1-year fellowship with Orange, flying mainly out of Toronto into the surrounding areas. I also have a research interest in pre-hospital critical care, and as I said, work as a trauma team leader at St. Michael's Hospital. So I see kind of the downstream effects of what first providers and paramedics can offer in terms of stabilizing patients and making early good decisions, how that then filters down through patient cares into the emergency department. And so I was just going to talk about 3 high-yield injuries, where I think in the flyer for this event it says something about you make split-second decisions and then they have a big impact down the line, and that's what I try to focus on. So things where I've seen little differences in management make a big difference down the line. And we're going to start with this. So this is certainly the thing that emergency medicine physicians do think about a lot, is what am I going to do if somebody comes in with a face that's smashed in, bleeding from the airway, because that always just makes things really awkward. And the way one of my mentors put this to me is, he said, so to be honest, it's very simple. You've got 2 jobs. Okay, the first job is you want to avoid aspiration. So whether that's blood going to the airway, that's definitely a bad thing. And actually you also want to avoid swallowing of a lot of blood, because people who swallow a lot of blood, it's very makes people then nauseated and vomit, and then they vomit a whole bunch of blood and other awkward things back up. So don't let the blood go to the back of the throat and either into the lungs or into the stomach. And the easiest thing to do is good positioning. So the reason I put this picture up is because that's, if you, within the restraint of a potentially entrapped patient, if you can keep a patient in that position, that is the right thing. And you let gravity do the work. So you lean the patient forward and you just let all that blood run out to the front of the mouth. It looks a mess. It doesn't look very exciting in terms of helping the patient, but it's absolutely key. And if you've attended the last webinar by my colleague, Tim Nutbeam, he's done some really important work in regards to thinking about our spinal control, and that sometimes other things are just more important. So yes, this patient might have a C-spine injury, but if he aspirates all of that blood that's coming out here back into his lungs, that's a higher risk of him having a bad outcome than a potential bit of movement through the C-spine in an awake patient. However, sometimes you can't achieve that position. The patient's truly unconscious, restrictions during extrication in particular. A lot of patients start up upright, but during the course of extrication, we need to lie them flat. So the next best position would be a left lateral. We traditionally do medicine to people when they're lying on their back, but that's really not a good idea in this situation because all the blood is just going to go straight back. And be very cautious of the trauma patient with facial injury who asks you to sit up. So we had a patient like that in the trauma bay. All he wanted to do was sit up and take off the C-spine collar. And this is where we could have made a decision to allow him that. And that would have been a good thing. Instead, we gave him a bunch of ketamine and lied him flat, at which point he promptly aspirated, had laryngospasm, and needed intubation because he just had contained bleeding that we didn't see externally that now started to go down into his lungs and made him block off his airway. So have a real good consideration whether you can allow patients to sit up, or if not, left lateral onto the left side, which I've been told before that is the standard position, I think, in Norway for transporting trauma patients without a secure airway. So airway always trumps spine control. That's, I guess, the key thing I want to say here. The other thing to consider is suction. So in this situation, in this picture here, actually, I would save my batteries for that suction because that blood is running out anyway. So all you're doing with suction in this situation is making it look a little bit less dramatic. But as long as the blood leaves the patient, I don't actually care about this. But let's say this patient would have to lie back because you need to extricate them. Then if they're alert, the best thing is actually just to give them the suction and say, here, like hold it where you feel you get the most effect from, because it's really difficult to be effective in somebody who's alert and awake, trying to suction for them. In the altered patient, you would just carefully try and see where do you get the most blood out through suctioning, but be aware that it's fairly limited in its effectiveness. Particularly, I have the old school Yanko sections. So there's larger bore ones like the Ducanto catheter, which is what you really want for that. So that's job one done. And for most trauma, that's all you need to do, is ideally positioning, if not suctioning. And then rarely, really, do you need to think about job two, which is avoid exsanguination. That usually happens if there's quite a lot of damage. So this is a 3D CT scan of facial bones. And just in case you weren't quite sure where things went wrong here, it's all of this. All of this in the red circle is broken. So this is a massive mid-face fracture. And they can bleed a lot because now you're getting into plenty of arteries around there that can bleed a lot more brisk. And this is now a real challenging thing, particularly if you've got a patient who's still entrapped. And your first consideration is, can you get this patient out there really, really quickly? Because whatever you need to do next is going to be a challenge unless you've got good access to the patient. And what we would do from a more sort of critical care point of view is step one is always to secure the airway, because you can't really do anything until you've got that protected. So we try to intubate, or if that is impossible, then maybe even the front of neck access, but something to secure the airway. Then the next step would be bilateral nasal packing with either custom-made balloons or a Foley catheter. Following that, manual reduction. So you put your hand into the patient's mouth and just try to move that maxilla somewhere where it might belong. Just reducing those fractures might reduce the amount of bleeding. And then final step is splinting, where we put bite blocks between the patient's molars to sort of splint the chin against the maxilla, and then put a C-spine collar on. So you just put like a force through the length of the face to immobilize all these bony fragments. But that's really sort of fairly advanced here down the line. And as I said, you need to get there first, like getting the patient out of where they are quickly. If you really, really, really can't do that, and that's why I put this in brackets, you can technically try manual evacuation of clots. So when people bleed a lot from their mouth, a lot of that blood clots inside the mouth, and it's really challenging to figure out where that bleeding is coming from. So if you really don't have option 2 here available, i.e. securing the airway, pack, reduce, splint, then you could try and like move all of that clot out with your fingers. The suction isn't going to help you. It's just going to get stuck on the clots. Move all the clot out that you can, and then see with a headlamp on if you can find a bleeding source, and then put your finger on there. You can put some TXA soaked gauze on there, direct pressure, see if that does the trick. But that will be a real challenge. So 2 jobs: avoid aspiration. Most of the time, that's all you need to do. Sometimes you get a second job, which is a lot more challenging, which is to avoid exsanguination. And the decision whether you need to worry about too very much is basically to just watch the patient. So we had an airway bleed recently, and then when I debriefed it with a medical student, she was like, I got a bit worried because I thought you weren't going to do anything. I was like, what do you mean? I was like, well, you just stood there and looked at the patient. I was like, oh yeah, I guess I did, because it's basically, the patient was leaning forward, blood was coming out. It's great. They're not aspirating. Part one is done. And then I just watched and looked how much blood is coming out to see, is this patient going to exsanguinate in the next 5 or 10 minutes, in which case I need to do a few things very quickly, or is it at a sort of pace where I can replace it with IV fluids, blood, and then we've got some time to think about this and be careful about it. And luckily it was the second situation. Great. So just a quick mention of tension pneumothorax. They're not all that common, but it's just a very reversible pathology, potentially lethal, very reversible. So worthwhile quickly talking about it. So again, red circle, there's lots of air outside of the lung down here. And then you can see these stria there. That's basically air that's not pushed out of the pleural space into your pectoralis muscle. So it's called surgical emphysema, what you'd feel as these crackers under the skin when you palpate. And a few things to think about is, as Evan sort of alluded to, your physical examination is very, very challenging and not that helpful sometimes, because you can't really hear much. So feeling and looking is a much better option, but again, you might have limited access. If you have something like point of care ultrasound, that is actually a great option for this, because you need very limited space on the patient, and you get a very definite answer whether there's a pneumothorax or not. There's been a lot of discussion back and forth around this. So needle versus finger thoracostomy. Going back a couple of years or decades, needle thoracostomy was certainly the primary treatment. And then we had a lot of research coming out that showed failure rates and it not working very well, and that we should move more towards finger thoracostomy, which I generally agree on. It's just that takes resources, training, and time. And really, some of the problem with needle thoracostomy isn't so much that this doesn't work in itself. It's that we took equipment that was made to take blood out of patients' veins, and then we stuck it into people's chests for air, and then we're surprised that it doesn't work so well. So time's moved on, and if you have a dedicated thoracostomy needle set, that actually does work very well for pneumothoraces. It doesn't evacuate blood, but it will relieve a tension pneumothorax very reliably. And then the same discussion sort of goes around position, where initially it was always the anterior, so second interclavicular space, and then increased failure rates, so we went more lateral. And again, I don't think it really matters. As long as you've got the right equipment, you can do either a needle or a finger thoracostomy in either of those two spaces. And if you have an entrapped patient, you might just have to work with whatever works for that patient in terms of access and skills of the scene. The important thing is, if you think there's a tension pneumothorax, that some sort of decompression happens as early as possible. Great. So towards the third big injury pattern, particularly in your blunt motor vehicle collision type traumas, is the pelvic fracture. And certainly in hospital, I'm not sure how it works. We always learn about this. So your different 3 types of forces. You've got your lateral compression on the top row, where the force comes from the side, so your classic T-bone injury. Then your AP compression, force comes from the front, classically your motorcyclist going into a stationary vehicle. And then finally your vertical shear, which is classically a jump from height or fall from height, or it could be again a motor vehicle accident where the one foot, the force goes through that leg and then that pushes up there. And that's sort of okay. It's very clever and it makes a lot of sense. It doesn't help you an awful lot when you're at the scene of accident, to be honest. So the way I would think a little bit more about it is more like this. So your first question is bony stability. And for that, you have to appreciate that the pelvis is a ring. And if you break the ring at one point, if it just breaks a little bit, that's fine. But as soon as you get more distraction at that one break, it has to go somewhere else too. And often that somewhere else is here in the back where your sacroiliac joints are. And the reason I care about sacroiliac joints isn't the bone. So we sort of get a bit distracted thinking about bones, and they're important if you're an orthopedic surgeon, and they're important if you're a patient who wants to have good long-term outcomes. But in the moment, what I actually care much more about is blood vessels. And that's why pelvic fractures are important. It's because in the back here, particularly across the SI joints, is a lot of what's called the venous plexus, so lots and lots of veins. And about 90% of the major bleeding from pelvic fractures, it actually doesn't come from arteries, because arteries have muscles in them, and then as the blood pressure drops, you get muscle spasm, and actually bleeding stops. But veins just don't do that. They just keep bleeding at a lower rate, but it doesn't stop. And that's what we really worry about. So you can kind of forget about the bones for a bit, worry about the blood vessels and the bleeding. So here are a few quick examples. So what happened here is that right femur got pushed up into the acetabulum. That all breaks. Iliac wing comes off here. I don't actually know if you can see my pointers. I've also got these little red circles. But importantly, the ring is intact and the SI joints are not involved. So this kind of pelvic fracture, it's going to be very painful. It's going to need surgery. It's an important injury, but it's very unlikely to result in any life-threatening bleeding, particularly early on. So next example. Again, we've got actually the same mechanism. So that, again, femur gets pushed up, acetabulum gets broken here. And again, that's an orthopedic problem so far, but not necessarily a bleeding problem. But then what also happens is that now the ring gets interrupted here at the symphysis anteriorly, which means one part of the ring is interrupted. There has to be a second part that's gone. And now you've got widening here at the SI joints, and all these veins that run across there can start to bleed. And then one final example. So this is a completely smashed anterior pelvis. So this is very likely somebody who maybe rode their motorcycle into something or a very high-speed car accident. You can see the ring is completely interrupted. And importantly, again, here at the back, that's completely separated. So this patient was very hemodynamically unstable because they're just bleeding out of here. And at the same time, this whole structure, as you can imagine, is very unstable. So you put any force into this from any side, the whole thing will wobble. And the reason we worry about the bones moving around is it hurts, but again, we can deal with that. But every movement around here where that bleeding's coming from just poses the risk of more bleeding developing. So little veins that might have stopped bleeding, you move it around, bleeding starts again. So that's the key thing I want you to think about is there's lots of blood vessels that will continue to bleed as long as we keep moving the patient. So what can we do about it? There's a real good article up here. I've put a link in RChem Learning. If you just Google RChem Learning pelvic injuries, you'll find it, which goes into this in great detail. But the key points really are these, and I want to make these all bold because all really important. But so your physical examination is extremely unreliable. So we still have our junior orthopedic doctors declaring the pelvis is stable, and I've x-rayed more than one pelvis that was stable on clinical assessment that had a horrifically open book pelvic fractures. So there's no real point of rocking the pelvis because the information you get from that is useless. You will not one way or the other say that this pelvis is stable. What you might do, though, is opening up those SI joints a bit further as you push down and cause more bleeding. Not infrequently, these patients are actually sort of okay in the beginning. So they're sitting there in their car, they're entrapped. And actually, there's very little space. They haven't moved since the injury. So they might have lost a bit of blood, but then that stopped and tamponaded itself. But as soon as we move them, that's when you just have to be prepared for this. That somebody who looks quite well at the moment, on the first movement, that might set a chain of events in reactions in motion, which 5 minutes later leads to cardiovascular collapse in terms of just worsening bleeding into the pelvis. So you want to have a few things ahead when you before you move that patient is where you're going to have space to then put in an IV or an IO, where you're going to further manage them if they collapse. And again, absolute qubit. So as we used to worry so much about not moving the spine, which in retrospect, probably a lot of this isn't as important as we thought. But I'm actually all about minimal handling, but not so much the spine as about the pelvis. Okay? So don't rock it, and also try not to roll it too much. There's very little information in blunt trauma that you get from a lock roller. But if you imagine you take this extremely unstable pelvis and you turn it 90 degrees on its side, now you've moved all these bones around, and then you move it back, and then all these bones move around again. So you just got to weigh up the benefits from doing things like lock rolls against the risk of causing further bleeding. So when I worked with Great Western Ambulance, we had a very standardized packaging protocol where all these patients would we would use a spinal board for extrication, but then instead of rolling them off that and rolling them on the next thing, we would just use a scoop stretcher where you only have to tilt the pelvis ever so slightly to get one side on the pelvic binder at the same time, then very light lift on the other side, and then you can transport the patient on the scoop stretcher, put them onto the emergency department trauma stretcher without any further movement. So your total rotation of the pelvis during that whole course is about 30 degrees, compared to if you do all of our standard rolling, that takes us to about 360 degrees. And that makes a real big difference in terms of the risk of catastrophic bleeding. And then pelvis binder, just wanted to mention what's really, really useful is if it should really be to skin, because some of these will stay on in hospital for a few hours until the patient goes to the OR or other interventional radiography. So it's always slightly disappointing to see a perfectly placed pelvic binder over a pair of jeans, because they're like, we can't get that out now unless we open that pelvic binder again and we kind of undo all the good work you've done. So take those extra 10 seconds and just cut off any clothes. It needs to be to skin. You can leave a bit of underwear on for modesty's sake if needed. And the level, so frequently these are applied to high, and I hope you've heard this before, but it's the level of the greater trochanter, which sits here, which means the pelvic binder should look something like this. And that's really important because it's not actually about pushing the pelvis itself back together. It's about putting force into the femurs to cause internal rotation. That's really what you're achieving. And then that closes the SI joints and reduces the volume inside the pelvis where bleeding can happen. And it also, so here's some sort of concern. So what about those iliac wing fractures up here, which you then potentially make worse by pushing them in? And the answer to that is it doesn't really matter because the pelvic binder never really touches them. It sits way below all of that over the femurs. And really, even if there's a iliac wing fracture that's already pushed in, you're really just making the rest of the pelvis catch up with that. So I wouldn't worry too much about that risk. And with that, I'm going to hand over to Brad.
Perfect. Thanks, Johannes. I'll just pull my screen up here quickly and start sharing. We should be all set, ready to go. So my name is Brad Bomber. I'm a critical care paramedic. I've been with Orange for close to 15 years, and concurrently I spent about 10 years in the fire service as well, primarily focused on auto extrication, but also a number of technical rescue disciplines, including high angle swift water, confined space, and a number of other rescue related elements. I have a very deep passion for working in the austere environment, and I do that globally, which creates a number of challenges that I tend to really appreciate because I think it really buys into the pre-hospital response consideration. And the reason I say that is because we are often tasked in pre-hospital emergencies to go places we've never been before, Depending on your center and your interagency relationships, you may be working with people that you don't have a consistent relationship with, or people that you don't train with on a regular basis. And depending on the sheer size of your organization, even your direct partner who's assigned you on your asset, maybe somebody new and unfamiliar with you. And I say that after working a couple of operational shifts on our asset this weekend where, I worked with somebody for the first time and we found ourselves doing some very dynamic calls, and it really highlighted the need and the value of having good interagency and team performance. And I think that's how I'm going to speak to the group here as we kind of cement some of those ideas as we move forward. So I'm going to start with the 0-point survey. This has been around for several years. I certainly can't take credit for it. This is the exceptional work of some world leaders in terms of team dynamics and crew collaboration. Their names are cited at the bottom there, and if you haven't seen this before, there's a very comprehensive document that really supports the most effective way to do this. And there's some good talks that have been presented over the years through different platforms, and I highly recommend you take the hour and a half, 2 hours, because it is very influential and practice changing for you. But to condense it down to a few minutes, the 0-point survey is really about creating an opportunity for success in both yourself, your team, and the environment that you're going to perform in. And a lot of the times when I talk about this with our learners in our organization is we spend a lot of time talking about self-performance and what that looks like. Because for a lot of people, we look at self-performance from a perspective of, getting mission ready when the hotline or the phone rings because you're being tasked. But the more you dive into it, the more you appreciate that this actually starts long before you show up ready for work. In many occurrences, it happens, the night before your shift to ensure adequate rest and good sleeping and eating habits. And then obviously there's a transference effect as we look through the next several days if you're working a consecutive shift pattern, because every day really impacts your ability to set yourself up for success and make sure you're fit for duty. The T is obviously in relationship to the team, which often talks about team roles, identified leaders, briefing going into some of these complex situations that we're dealing with, and in the paramedic services and in the fire service, because I know there's a number of you who work in the fire service specifically. We do a pretty good job of establishing what those look like. But as an industry and as in response organizations, where we kind of struggle is how do we do this in the multidisciplinary setting where you have police, fire, EMS, and other services responding to the same incident. And if we don't train together, it's hard to establish what those roles and those responsibilities are. And it's one thing we've learned plenty of times before is unless you train with these individuals, we have an appreciation for what they do through experience. But until you actually have some fruitful conversation around what they're trying to accomplish out of their objectives, you really only have a superficial look at the big picture perspective. And sometimes we need that big picture perspective if we are going to operate seamlessly together. So a take-home point there is whenever you can take advantage of some interagency collaboration and some training, certainly encouraged to do so. We have explored this opportunity in our system on many occasions. Johannes was part of a heavily involved training exercise with one of our local fire departments when he came into the organization, and it built relationships, but also gave a large appreciation for the capabilities and the knowledge sharing that exists between two very unique rescue specialists. As we transition to the P and then the up aspect, that's really during the resuscitation piece. And a lot of it has to do with absorbing the information that the patient's providing you, providing consistent updates throughout the team through a shared mental model, and constantly assessing what your priorities are, and then using those priorities to influence change. And where this step-up approach is most impactful when dealing with traumatic patients during motor vehicle collisions is all these things are exceptionally important because your needs from a human resource requirement, your patient requirements, how you manage the scene and the environment are very dynamic when dealing with motor vehicle incidents. And frankly speaking, any technical rescue element, because those needs and those safety elements constantly change. And very frequently, you're going to adjust those priorities depending on your patient presentation and whether or not your plan A, B, and C found success. So it's important to have some contingency planning in place as you move forward. The next piece I wanted to talk about and kind of highlight briefly in terms of trauma is largely around the kinematics of trauma. And essentially what that means is, what are traumatic injuries and why they occur? And what this really comes down to in a lot of cases is pattern recognition and having appreciation for what's going on. So if we take a individual who's diving into a lake, for example, and you're responding to this call, if you've had the ability to respond in one of these occurrences, you go to that situation looking forward, the potential of an extrication in the water or looking at a high C-spine trauma, and there's a number of questions that come out of it. But when you actually look at the injury pattern, you're often engaged with some facial trauma, some head and neck trauma associated with it. If there's an element of paralysis, then you have to deal with the physiological effects and how you're going to create a care management plan around that. But for any of you who have responded to this nature or have thought about this before you even arrive on the incident, you can kind of anticipate like what's going to happen and some of the likely physical and clinical findings that you're going to endure, which helps guide your strategic plan. And then if you take that information and you articulate back to the step up, you can already start creating a treatment plan. You can start looking for identifiable features that draw a conclusion and reaffirm kind of those intuitions and that gestalt that you had from a clinician perspective. And you'll find the more that you do this, depending on certain patient presentations and certain types of injury patterns, especially in the settings of trauma, that these things are repeatable and we learn from them, and we learn from them often. And depending on your experience, your ability to draw those conclusions and look for those pertinent clinical findings and those pertinent negative findings become much more readily available to you. So I took the opportunity to find like a low-speed motor vehicle collision, and underneath it, there's certainly some language there. So while I talk, if you want to highlight a couple of the patterns from motor vehicle collisions, but there's a fairly robust set of information there. And then by absorbing that information and kind of storing it to memory, you can appreciate kind of what goes on. So in that front impact collision, there's a lot of forward-facing momentum that goes through. That's the kinematics, that's the energy portion. If you're the driver in that blue car, you find yourself striking the steering wheel. If you drive close to the steering wheel, you're looking at some of those chest, sternum, pericardial effusion, cardiac tamponade, lung injuries that Johannes and Evan have spoken about in terms of the management on how to deal with those. So when you pull up on scene or you get that information from your dispatch organization, you can start to create this mental model and this picture of some of the things that you might endure just based on the mechanism of the motor vehicle collision and what that looks like. Some of those things change depending on how the vehicle collision occurred. A T-bone MVC obviously has some lateral movements, and that's where we can get into some of the lateral shear aspects of the pelvis fractures that Johannes was talking about, or some of the flail segments on the ribs, and some of the requirements in terms of treatment for decompressing that tension pneumothorax if it doesn't exist. But we can also look at some of the more complex issues around, how do we extricate some of these patients? We often look at seatbelts as a life-saving measure, and they are certainly worth the risk because in any kind of motor vehicle impact, we have all seen the evidence of seatbelt injuries. And the big kind of take-home point there is for individuals that don't wear their seatbelt correctly when they do find themselves in an incident, you are at high risk for some of the splenic and liver lacerations associated with a high seatbelt from the significant deceleration injuries as it relates to the sudden stop of a motor vehicle collision when that belt lap is actually higher than it should be. Seatbelt injuries are also exceptionally common for the over-the-shoulder belts where they're connected because you get clavicular fractures, which I don't want to say are relatively benign, but in the setting of a motor vehicle collision, you could very well find yourself with a straightforward clavicular fracture, but a prolonged extrication time, and now you have a developing pneumothorax because of the internal trauma that occurs as you try to extricate that patient, and you have the rigid, jagged aspect of the clavicle and the crepitus that occurs, basically influencing and coming into frequent contact with the very sensitive tissues around the lungs. And those are some of the considerations that we have to talk about when we weigh the risk and the benefit of extrication and how we do it in a timely fashion while providing supportive measures to the patients. And then to conclude, the final image in the bottom right corner, this is an image from a heavy urban search and rescue incident where this individual is actually like trapped and had some compartment syndrome and had some crush injuries. So as you can see, between the three diverse mechanisms of injuries associated with trauma, there's distinct injury patterns that are involved, but all these things can largely be forecasted before you even arrive scene, which just helps you establish yourself in that mental model and that frame of understanding, so you can predict and anticipate what's going on with the patient. And then when you combine that cognitive load that you're creating pre-patient contact, and then you utilize your skills as a practitioner at the bedside while you assess the mechanism of injury of the incident and the physical findings of your patient, now all of a sudden you have a very comprehensive understanding of what's going on with the patient, which includes what the patient needs are in order to be successful in getting them extricated, treated, transported, and arriving at definitive care in an optimal patient condition. I think another major consideration that we need to talk about from a trauma management perspective, especially as it relates to high impact and low impact occurrences, has to do with frailty and trauma. And the phrase frailty and trauma is more of a positive increasing trend. We used to often think about frailty and trauma, and it was underscored as like geriatric trauma or advanced aging elderly trauma. And the reason why I highlight it here is because there is significant physiological changes that happen with aging. And I think for anybody that's been practicing for any period of time, you probably appreciate those changes. But the industry culture is getting away from calling it geriatric trauma because, you know, there are some incredibly fit 85, 90-year-old people out there who would probably put me to shame in terms of physical fitness because of how active they are. And on the inverse side of that relationship, there are individuals who are significantly younger, who are very frail and petite or have underlying pathologies that makes them exceptionally susceptible to injury. So when you arrive on some of these scenes, you know, it's great to look at the physical injuries that the patient has sustained, but we also need to consider the implications of how likely that patient is to endure physical stress and trauma and actually be able to compensate from what's going on. And I think for most people, when you think about frailty in the elderly or frailty and trauma, we often consider like the elderly petite person who has like osteoporosis and they're very susceptible to fractures. And I think that's a statement of image that we have in our mind often. And it's just important to note that, you know, you could have a 20-year-old with advanced medical conditions or a 30-year-old that has those same considerations. And those individuals are equally at risk for some of the complications associated with just having a frail structure that impacts and absorbs a lot of those injury patterns. So a quick summary recap is the effect of agings. All of those considerations there also affect our ability to compensate in terms of injuries. And then the graphic in the bottom left corner that talks about characteristics really talks about some of the morbidity and mortality considerations of how our body transverses from some of the injury patterns. But probably more important isn't the original insult to injury, it's our ability to recover. And I think for a lot of individuals, we've been to the motor vehicle incident where a very frail person has a pelvis fracture or a femur fracture, and those are very survivable injuries, and they often go for 6 or 8 months. But if that person can't progress through active rehabilitation, then they find themselves in a situation where they get underlying conditions like pneumonias because they've been bedridden and they can't get up and be active and agile and get back to healthy, active living. So some of these minor injuries and the way we manage these patients in a pre-hospital environment and allow them to get comfortable has an impact on their ability to recover in a timely fashion. And that's why some of the early identification on these injuries and a good physical assessment provides an excellent knowledge transfer while these patients get definitive care in the receiving centers that they're going to, which ultimately reduces their in-hospital stay. In addition to the special populations, as it relates to frailty, we often look at pediatrics in terms of trauma, and we have to ask ourselves like how pediatrics respond in certain situations. And a lot of the times when we deal with these motor vehicle collisions, pediatrics tend to manage trauma like fairly well, but when they tend to decompensate, they decompensate quickly, and they are often quite difficult to resuscitate because they do hold this compensation threshold exceptionally well. And then when they deteriorate, they require a lot of times advanced resuscitative techniques in order to get back. So if you find yourselves in a position where you think you're going to have to manage a pediatric airway during an extrication early because they're quite altered, then it's really important to intervene in a very time-sensitive fashion using basic measures until any more advanced directives can be applied, and getting the right resources to ultimately the patient's bedside to facilitate some of those needs. Children that show signs of shock will demonstrate and deteriorate quickly, and often if a child kind of is in a pre-arrest state due to shock, again, like they require some of those advanced assessments in order to move forward. So we often prioritize the circulation of children in order to make them comfortable, get them ready, and pick up on the social cues. And I think one of the pearls that comes from the pre-hospital element is if you have a family or a bystander who's there and they're familiar with the child and the child's needs, it's really relying on that individual to provide you with some context so you can acknowledge like what is normal for this child. I've been involved in many cases where the child appears to be behaving normal for me, but when you talk to an older brother or sister or a parent, they will quickly identify that no, like they're much more quiet, they're not as engaged, the energy level isn't there, and those are all very alarming symptoms that we need to take considerably. And then the last pearl when dealing with pediatric patients, whether it's trauma or otherwise, is care management around pediatrics should be about a care management plan. It should be about integrated care management. So if you have a kid who's quite sick, even if they're gravely ill, keep that family member bedside, keep the parents close by, have a resource engage in them in the conversation to help them understand kind of what's going on, because you're not just treating the pediatric patient, you're treating the pediatric patient and the entire family that's associated with that traumatic incident. And more often than not, despite best efforts, like those situations get remembered for your care, compassion, and empathy at the bedside by having an integrated care plan with the family who are involved. And that extends well beyond the pre-hospital environment and straight into the in-facility aspect. And it's certainly something that it's trending in the right direction. So if you get a parent on scene who's difficult, appreciate why they're difficult, but you'll never separate those two individuals while dealing with the core problem. And they will often provide a tremendous amount of support in helping appreciate how that child is progressing while you do extricate that individual into the field. I won't do a high-level recap of some of the complications associated with the pregnancy patient who's involved in a traumatic incident like a motor vehicle collision, but it is something to be exceptionally mindful of because there is a lot of underlying pathology that happens when pregnancy occurs and the physiological changes that mom has, which allows her to actually hide some of the severity of the injury sustained. So any pregnant patient should be dealt with a very high index of suspicion, and any real vital sign changes from about 10% of normal are considered high risk. And for services that have the ability to use a fast ultrasound, the sensitivity is extremely less when dealing with a pregnant patient. So there's just a couple of pearls to be mindful of while dealing with these individuals. And then the last special populations group I'd like everybody to consider really has to do with the complex medical patients who have underlying pathologies that influence our ability to really assess, manage, and treat, and the patient's ability to compensate from injuries. So, patients who have cancer undergoing chemotherapy, their index of suspicion and their risk to significant internal injuries and musculoskeletal trauma is significantly higher because of the side effects of their treatment pathway. And then some of the other major considerations are, we often look at trauma, but we don't often have good conversations around the underlying medications that a patient takes. So things like beta blockers really blunt our ability to appreciate tachycardia and the shock-like statement that a patient's in, or what a normal mounting blood pressure could be in a head injury if it's blunted by medications that don't allow somebody to become quite hypertensive. Anticoagulation or blood thinners is detrimental to trauma care. And again, going back to the frailty and the appreciation of individuals, I've picked up people who are 20 years old who take blood thinners for different underlying conditions. And unless we know, we have to ask the question. And then finally, comorbidities and mortalities, and whether or not people have significant injuries in the past. And one of the big considerations is when you deal with musculoskeletal trauma, like you might have somebody who has few spinal vertebrae in their discs and like poor range of motion and muscular aspects that have to be considered when you extricate them. And sometimes that creates some challenges because you can't position them on your stretcher in a very typical way. So as we go through the final slides, I know we're kind of coming close to time. You know, this motor vehicle collision looks fairly straightforward and relative with the technology that we experience in today's conditions. Like most people would consider this a very minor MEC, but if we use the step-up approach and we look at some of the special patient population groups and we take that information and we combine it with some of the injury patterns that have been talked about and Johannes discussed earlier, this could actually be a very significant injury for somebody. You know, if you had a frail individual in that front passenger seat and they had, you know, thoracic chest trauma, like how do you properly extricate them? Often we would take them out the driver's side of the vehicle, but what do you do if there's an embankment or a Jersey Shore barrier present there? Maybe that patient becomes unconscious. How do you help manage that airway? This can be a scrutinized extrication strategy, but there is several large city departments all over the world from a fire perspective who will actually separate these two vehicles and do them safely to give them access to that passenger side door to create a more timely response. And if your service is doing that, you're probably on the cutting edge of some of the rescue techniques available. And if not, it is something to consider. But there's been a 200-year history of not doing that for various reasons as well. So that's a dynamic change. And then concurrently, when you look at an injury pattern like this, you know, the damage to the vehicle is catastrophic. For a lot of departments, this could easily be a 60-minute extrication window. And when you have somebody in the front seat or even the rear seat of that vehicle, what this comes down to is you may have to compete your priorities between extricating the patient in a timely fashion, but also providing definitive high-level quality patient care to correct some of the life needs. And what does that look like? And I think one of the take-home injury patterns that we want to talk about just very briefly when we deal with these kind of catastrophic front impact collisions is when the firewall pushes up on the vehicle, we often lose situational awareness of what happens in the wheel wells. And injury patterns that are very typical are those bilateral tib fib or lower extremity fractures, where you can have a patient that starts out being, you know, reasonably stable. Often you would see a pelvis injury just because of the kinematics and how this force happens. But if you have somebody with an open fracture in their lower legs here, and you can't do a good secondary assessment, which we tend to leave till after the patient gets out of the vehicle, then there's a good opportunity that that patient could be exsanguinating into the wheel well. And until you can get down and assess their lower extremities, you can't measure your success on how much they can bleed. And this is one of those considerations where you may think you have time because your patient's alert and oriented and talking to you, and it comes down to reprioritizing your task and your mission profile, because that time will quickly run out over 15 to 20 minutes as that patient continues to bleed, which may influence your extrication strategy from an organizational perspective. So in summary from across the discussion today between the three of us, I think some of the key take-home messages are, you know, you need to have an organized approach to your medical and scene management, which includes your resource and asset availability, and constantly reprioritize and what that structure looks like. Consider the specialty resources to support the mission profile when dealing with extrication initiatives. And I've been really highlighted the approach to patient assessment and why it needs to be consistent. If you constantly do your trauma assessment the same way every single time, the probability you're going to miss something is exceptionally low. So if you continue to commit to that pathway, you'll pick up on a tremendous amount of opportunities versus having an unorganized approach. I'm going to stress the importance of a peer incident assessment and review, or a debrief. And the reason I do that is because we often learn from the situations we've been engaged in, and that's how we develop an experience. So I encourage you to talk to your colleagues about calls you've had, follow up on patients, take the injury pattern you saw in the field and see if that resembled after they've received like a CT and diagnostic imaging, and how close were you, because you'll develop this internal library of information to draw on for your next clinical case and your next extrication strategy. and then use that information to support your awareness and your understanding of the clinical kinematics of trauma and how it relates to these individuals. So with that notes, I certainly appreciate your time today. I had a lot of joy and pleasure in providing some information to you, as I know Evan and Johannes did as well. And there's some contact information if you'd like to reach out to any one of us to engage in some future conversation. And I'm happy to open up the discussion for any questions that the group may have.
Thanks, Brad. Thanks for that. And thanks to you all for Johannes, Evan, and Brad for your input. Really interesting input when you tied together the knowledge and understanding with the practical examples that you provided. I think was really of real value. I know that we are slightly over time, but we have a question here maybe you could answer for us. In the context of immediate treatments, what role does pain management and emotional support play in enhancing overall well-being of trauma patients? So I don't know who will answer that, but I'll just leave it up to you to just answer the question. Thanks.
I can make a stab at that because that's a really important question. And one thing we do occasionally see from a hospital perspective is this fear of giving analgesia for concerns of whether it's hemodynamics, reliability of assessment. And I think I really want to take that out. A lot of things get a lot easier to assess when the patient had adequate pain control. So frequently somebody comes in tachycardic. Is that due to bleeding? Is it because they're just in a lot of pain that's not being controlled? So not giving analgesia is not an option. You just got to do it carefully and titrate. And that's, I guess, that's the way I cook is you can always add more. You can't take stuff away. So if you're uncertain, you just start at a very low dose of something like fentanyl or ketamine and then work your way up. You don't have to solve the problem within 10 seconds. But you need to start the process of giving analgesia, and you'll learn with every dose that you give how that affects the patient, and you titrate your way in. Okay, and that's got some really long-term, I think the psychological benefits of that is probably very understudied, but I would assume that is really, really valuable for survivors.
Thanks, Johannes. That's really interesting. Also, I know Brad just mentioned there he rounded up a number of areas and what we should look at, but I'd be interested to find out what the one takeaway that you'd want the audience to take away from your own personal perspective in relation to the theme. So if I can maybe just start off with Evan. Evan, what would you want the audience to take away in relation to one specific aspect relating to your talk?
I would say probably just the usefulness of picking a structured approach, no matter what that approach is, something you're comfortable with, something maybe you were initially trained on, and just really prioritizing using that consistently. And that it's almost a place of comfort that you can come back to when you show up to these scenes, depending on what kind of services you work for. Maybe you see this every day, but maybe you see this once a week, once a month, once every 6 months. So having that approach, I think, is crucial, just to come back to a place of comfort and know that you're going to provide excellent care without missing anything.
Oh, thanks, Evan. And yourself, Brad, what about yourself?
I'd say the most important thing is the ability to engage in your colleagues and create those relationships by having that post-incident debrief. And the reason I select that one, it's kind of twofold. One, it builds team dynamics and helps create relationships. It also creates a safe space in your organization, so you can sit there and have conversations and explore, the variability of just how we do things. And when people start to do that, you're going to find your interagency and interdepartment professionalism will go up, and you're going to shift from, this culture of people scrutinizing one another to a culture of learning. And when people start getting on that page together and they feel safe doing so, people will expand their knowledge. And by taking that information and talking about some of these difficult cases that we manage, especially from a trauma situation, there is quite literally dozens of ways we can extricate patients and create a care management plan. But by having some frank conversation in that safe space where we feel comfortable doing so, you're going to really expand your knowledge and your understanding and your ability to seek out those opportunities. And when you start doing that, I think what's available to you is really endless, because the amount of resources, both formally and through like different courses, and the number of like distance ed programs available to trauma management and extrication, they're really like endless at this point. And then it's just a matter of, you know, being interested and willing to pursue that and put yourself on a limb to learn new information and move forward. And I say that because it's not just isolated to like trauma management, but I think that's a transferable skill to a lot of the management that we do in medicine. And I think that's a transferable skill to just good life skills in general. So I think that's a big one for me.
Okay, thanks, Brad. And finally, Johannes.
Yeah, I'll bring it back to, I guess, more sort of immediate patient case. It's a very dynamic process, extricating a pre-hospital scene care and making if-then statements. So it's about where are we now, and then if this happens, then we're going to do this. So if we're pulling out this patient with a facial bleed and they start obstructing the airway, then this is going to happen. So that it's about being prepared and proactive compared to being reactive. And one way to make that very simple for your team is getting in the habit of making if-then statements.
Okay, thanks, gents. Thanks very much for that. I know